Hi, we're going to begin talking about contraception and fertility by Professor Diaz. Before we begin, I want to talk about what is contraception. So these are strategies or devices used to reduce the risk of fertilization or implantation to attempt to prevent pregnancy. So just kind of going back to human reproduction, one of the things that occur when a woman before she has her menstruation, she will fertilize an egg. And that once that egg um, is released and into the fallopian tubes, it becomes fertile, and she's going through this ovulation, and it's fertile for 12 to 24 hours. And so during that time, if she has intercourse, and the sperm enters the vagina, it can actually stay viable within 48 hours to 120 hours, which it can equates to 2 to 5 days. So if the timing is right, they can potentially fertilize and she can become pregnant. So one of the ways that she can avoid pregnancy if she's not trying to get pregnant, then that's where they need to decide if they wanted to choose to use some form of contraception. So family planning methods consist of preventing pregnancy until a desired time. So let's begin about talking about family planning. So two components of family planning, it can be that a couple are planning to have a baby or they're trying to prevent having a baby. So if they are planning to have a baby, one of the things they need to consider is preconception care, which is very, very important, because in this preconception care, it can address nutrition. So if there's, just any trying to get them to eat healthy, having a diet rich in folic acid, especially because, one of the things that you want to be telling moms before they become pregnant is that they should consume folic acid, which is within their vitamins, at least 400 micrograms, because that helps decrease neural tube defects. Exercising, nothing strenuous, just moderate exercising. Lifestyle changes. So if they're drinking alcohol or doing any recreational drugs or anything like that, that's something that we would like to change prior to pregnancy. Chronic illnesses or genetic disorders, those are things that we want to talk about in this preconception care, so that it can actually address if there's any health concerns. And then medication, you want to also know what medications they're on, because that definitely can affect pregnancy, especially if it's a drug that can potentially harm the baby. So in this visit, the nurse's role is answering questions, general questions concerning contraceptive methods. You want to explain the different methods that are available, so you want to always talk about the risk and the benefits, advantages and disadvantages, teaching the correct use of the contraceptive methods, and that helps allow the patient to make an informed decision on whether or not they choose to use this contraception. So again, you want to support the client in making the best decision for their individual situation. So factors that influence choice of contraceptive methods, it could be due to age. Some contraceptions can't take when you reach a certain age, and we'll talk about that when we start talking about different types of contraception. It can also depend on your health status, and depending on if there is any health concerns, that may be contraindicated for taking certain contraceptive methods. Religion or culture can also play a role. Impact of unplanned pregnancy on the woman or family can play a role. Desire for future children. Frequency of sexual intercourse could also be dependent if they need to be on any kind of birth control method, especially if someone's practicing abstinence. Convenience and degree of spontaneity desired, because again, some may find it inconvenience to use certain contraceptive methods. Expense can play a big role, because if they don't have insurance and if it doesn't cover, that can be an issue. And then again, the number of sexual partners this person may have. All right, let's begin talking about natural family planning. So natural family planning involves learning to identify the signs and symptoms associated with ovulation, acceptable to most religions. It requires no administration of medication or uses of devices. Its natural family planning is and its failure rate is about 20%. So with the different types of family planning, you have abstinence, coitus interruptus, which is known as the withdrawal method. There's a calendar rhythm method, basal body temperature, and symptom-based method. So we'll talk about each of those in the next slides. So first what we're going to talk about is abstinence, abstaining from having sexual intercourse. So the client education, you want to be talking about making sure that they refrain from sexual intercourse if they want to be abstinent. Finding alternative ways for gratifying activities such as touching, kissing, holding hands, massage, or oral and manual stimulation. The advantages of those, it's effective birth control method, and you're abstinent during fertile periods, and again, it prevents risk of STI as long as there's no genital contact. The disadvantages, well, it requires the person to have self-control, and there's no protection against STIs. So the risk is if their complete abstinence is maintained, then there's no risk of STIs. So we have the withdrawal method, and that basically means when the withdrawal of penis from the vagina prior to ejaculation. Again, that takes a lot of self-control as well from the male part perspective, because again, they had to pull out prior to ejaculation, and you want to prevent any leaking from the penis pre-ejaculation into the vagina, because then that can put the women at risk for becoming pregnant. Again, the advantage of this is a choice for monogamous couples who do not have another contraceptive method available. Again, the disadvantage is that it doesn't protect against STIs, and it's not the most effective because, again, it has the risk of still becoming pregnant just because if the male pre-ejaculates inside her, and that can, sperm can be deposited in the vagina and potentially risk of pregnancy. Okay, so we're going to go on to the calendar method, which is a woman records her menstrual cycle by calculating her fertile period based on the assumption that ovulation occurs about 14 days before the onset of the next menstrual cycle. So either at that point in time when she is fertile, she either will engage in sex if she's trying to get pregnant, or avoid sex if she's not trying to get pregnant. Because again, as you know, that the sperm can be viable for 48 to 120 hours, so that's about 2 to 5 days. And so if for all you know, the person can have sex 2 days prior and then becomes and then she's ovulating, and so they can fertilize the egg at that point. So they just need to be mindful of that. So with this, they have to record the number of days in each cycle, counting from the first day of the menses for a period of at least 6 cycles. And that's just to make sure that the woman is regular. This really works for women who are regular menstrual cycles. If you have irregular menstrual cycles, it's going to be a little hard to really track when you're ovulating. But the advantage of this is it's useful when combined with basal body temperature or cervical mucus membranes that we'll talk in the next slides. And it's obviously inexpensive because you don't have to spend any money on this. Disadvantages, it's not a very reliable technique. Does not protect against STIs, requires accurate recording, and requires compliance regarding abstinence during fertile periods. So the risk again can affect and change the time of ovulation and cause unpredictable menstrual cycles, and there's always a risk for pregnancy. So the symptom-based method is the cervical mucus. So this is basically a fertility awareness method based on ovulation. And usually when the woman is ovulating, the cervical mucus becomes thin and flexible under the influence of estrogen and progesterone, and allows for the sperm viability and motility. And it has the ability to stretch between the fingers to the greatest during ovulation. This is referred as spin barket sign. So ideally, the way that this cervical mucus should be is think of an egg white consistency, stretchy and watery, and that indicates that the woman is fertile at that point. So again, you have to teach the client to engage in good hand hygiene prior and following assessment. Begin examining mucus from the last day of the menstrual cycle. And mucus obtained from the vaginal introitus, so it's not necessary to reach into the vagina to the cervix. Do not douche prior to assessment. So advantages of this is that the woman can become knowledgeable in recognizing her own mucus characteristic at ovulation, and self-evaluation can be very accurate. Again, self-evaluation of cervical mucus can be diagnostically helpful in determining the start of ovulation while breastfeeding, noting the commencement of menopause, and planning a desired pregnancy. So some women are comfortable with touching their genitals and mucus, and therefore this method is maybe suitable for them. But if it's somebody that doesn't like to touch genital, then it might be a little hard to do this method. But it does not protect against STIs, and assessment of cervical mucus characteristics can be inaccurate if mucus is mixed with semen, blood, or contraceptive foams or discharge from infection. And again, there's always that risk of pregnancy as well. So you have your basal body temperature. This can slightly at the time of ovulation. This can be used to facilitate conception or be used as natural contraceptive. Measure oral temperature prior to getting out of bed each morning to monitor ovulation. It's inexpensive, it's convenient, and no adverse effects. Again, the reliability can be influenced by many variables that can cause inaccurate interpretation, and temperature changes such as stress, fatigue, illness, alcohol, warmth of sleeping environment. And again, it doesn't protect against STIs, and there's always a risk for pregnancy. So let's switch it up a little bit and talk about barrier methods. So the different type of barrier methods that we're going to talk about is male condom, female condom, the diaphragm, and the cervical cap, and spermicide. So male condoms is a thin rubber sheath a man wears on his penis during sexual intercourse as a contraception and protection against infection. And male condoms can be made of latex rubber, polyurethane, or natural membrane. And so they just want to make sure that if they're allergic to latex, they want to use a polyurethane or natural membrane to prevent allergies. For client education, you want to teach them how to place a condom on the penis. So what this, you can do like a demonstration, have like a cucumber and condoms, and demonstrate how to put it on the cucumber, and then have them do a return demonstration. Again, teaching them that following ejaculation, withdraw the penis from the vagina while holding on the rim of the condom to prevent spillage to the vulva or vaginal area. It can be used in conjunction with spermicidal gel or cream to increase effectiveness. Make sure not to open the package with teeth or sharp objects. Check expiration date. Do not use baby oil, vegetable, or petroleum jelly as lubricant. They should be using a water-soluble lubricant. And again, we want to remind them that most commonly men will put their condoms in a wallet. So again, that can destroy the spermicide. So they just want to not put that in there. So again, advantages: it protects against STIs and involves the male in the birth control method. No adverse effects, it's readily accessible, provides some protection from STIs. The disadvantage of that is its high rate of non-compliance, can reduce spontaneity of intercourse, and again, the penis must be erect to apply the condom. So there's always going to be risk factors or possible complications. One of them the condom can rupture or leak. It's always going to be a one-time usage, and people can be allergic to the latex and not know it, or only can use water. And again, you can only use a water-soluble lubricant to avoid breakage. The next one is a female condom. This one is a vaginal sheath made of nitrile. It's a non-latex synthetic rubber with flexible rings on both ends. The closed end of the pouch is inserted into the vagina by the client prior to the intercourse, and it's anchored around the cervix, and the opening rings cover the labia. The condom is removed and then thrown away after intercourse. Advantages is that it serves as the same purpose as a male condom. It prevents pregnancy and also protects from STIs, and it's pre-lubricated and it's a single use. The disadvantages of this: women may find it unattractive. There's a failure rate of 21%. But there is two styles. They can either have the top picture, which is kind of like the flexible rings, and that fits into the vagina, one remains out, or they have this different type of bikini panty style pouch that fits in the vagina and can be inserted up to 8 hours before intercourse. So spermicide is a sperm-killing chemical that comes in foam. It can come in a cream, a jelly, or sometimes a film and a suppository capsule. And again, this is inserted in the vagina before intercourse to neutralize the vaginal secretions, and it destroys the sperm and blocks entrance to the uterus. So it's effective for no more than an hour. Reapplication is needed for repeated coitus, and women should not douche for at least 6 to 8 hours after intercourse. Again, the failure rate is about 21%. It can be irritating and can cause tiny cracks, providing portal of entry of infection. The next method is the barrier methods. I'm sorry, a little tired here. Diaphragm and spermicide. So it's a dome-shaped cup with a flexible rim made of silicone that fits snugly over the cervix with spermicidal cream or gel placed in the dome and around the rim. It comes in different sizes, so the patient needs to get properly fitted by a provider. And anytime that she fluctuates weight or has an abdominal or pelvic surgery, or after every pregnancy, she needs to get refitted, and also it needs to be replaced every 2 years. And that's very important to teach your patients that, because people will forget. So it requires insertion and removal, and prior to coitus, the diaphragm is inserted vaginally, and they have to place that spermicide jelly and making sure it's nice and fit and secure. And they can actually have insert up to 6 hours before intercourse and must stay in place 6 hours after intercourse, but no more than 24 hours. Because then that can potentially be at risk for toxic shock syndrome, can lead to infection if it's put in there too long. And if they decide to have sex again, they need to reapply the spermicide on the diaphragm. Again, tell her to empty her bladder prior to insertion of the diaphragm, and it should be washed with mild soap and warm after each use. Okay, so the advantage of using the diaphragm, it gives a woman more control over contraception. The disadvantage is that it can be inconvenient. It can interfere with spontaneity and require reapplication of the spermicide gel with each act to be effective. Requires a prescription and a visit to a provider. Because remember, they have to go every 2 years or refit it if something changes. Must be inserted correctly to be effective, and does not protect against STIs. So the people that are contraindicated or complications is not recommended for clients who've had a history of toxic shock syndrome or frequent or recurrent urinary tract infections. This can increase the risk of bacterial infection. So if a patient is having a high fever or feeling faint or drop in blood pressure or having diarrhea or headaches or muscle aches, then they definitely need to see a provider. Again, proper hand hygiene aids in prevention of toxic shock syndrome, as well as removing diaphragm promptly at 6 hours following coitus. So, and again, there's a risk of allergy reaction, especially to the spermicide. The next one is the cervical cap and spermicide. And this one is a little rubber cap that fits snugly around the base of the cervix, almost similar to the diaphragm. It comes in 3 sizes. Again, it can be inserted 6 hours before intercourse, but this one can be placed, can be in there for no longer than 48 hours. Again, this one you need to replace every 2 years and refit it after any gynecological surgery, birth, or any major weight fluctuation. So again, this can be washed with mild soap and warm water after each use. Again, the disadvantages of it, that it can be a potential risk to get toxic shock syndrome, and that's mainly because they leave it in there for too long. Risk for allergic reaction, and does not protect against STIs. And again, it's contraindicated for a woman with abnormal pap test or a history of toxic shock syndrome. So let's talk about hormonal contraception. So we have several different kinds. We have regular oral contraceptive pills. We have progesterone-only pills. We have an emergency oral contraceptive. We have a transdermal contraceptive patch, an injectable progestin. We have a vaginal ring, an implantable progesterone, and a uterine device. All of these do not protect either partner from STIs, including HIV. Again, it's a form of temporary birth control. It prevents ovulation. It makes cervical mucus thick and resistant to sperm penetration, and makes uterine endometrium less hospitable if fertilized ovum arrives. Okay, so with this combination oral contraceptive, which is the pill, this contains progestin and estrogen. It acts by suppressing ovulation, again thickening the cervical mucus to block semen, and altering the uterine ductility to prevent implantation. So again, the advantages of taking pills is that it has a failure rate of 9%, reduces risk of ovarian, colon, and endometrial cancer. It helps regulate menstruation, especially if a woman suffers from irregular periods. It also helps with cramping because some women suffer from really severe menstruation, so this will help that. A lot of women experience a lot of lighter period when they're on birth control pills, less cramping, reduce PMS, and it also reduces aches. So again, the side effects with taking birth control pills is that it may cause nausea, it may cause a headache, maybe breast tenderness, and sometimes fluid retention. For taking people who are contraindicated for taking birth control pills, it's any person that had a thrombolytic disorder, so they had a blood clot, if they have a history of a heart disease or a stroke, that can be contraindicated, gallbladder disease, if they had uncontrolled hypertension or diabetes, or if they have an estrogen-dependent cancer or breast cancer, or if they have impaired liver function, undiagnosed vaginal bleeding, or if there's a suspicion of pregnancy or they're pregnant, breastfeeding, or smokers, or 35-year-old and a smoker. So again, these are contraindicated for birth control pills. Now, one of the things you want to educate your patients, because a lot of things you'll be doing is educating your patient, so you want to tell them about warning signs and complications. So one of the complications that can happen with taking birth control pills is what we have this acronym called ACHES, which if they have any abdominal pain, chest pain, dyspnea, bloody sputum, any headaches, weakness or numbness in the extremities, eye problems such as blurred vision, double vision, or vision loss, or severe leg pain or edema or speech disturbances, then they definitely need to notify the provider. So again, we teach patients how to take the drug because they have to take the pill every day, and then they get 1 week off for their period. So you have to teach them that if they miss a pill, they need to take it right away. And if they miss it twice, then again, they have to follow the directions and make sure that when they do ever miss a pill, that they have to use a backup method. And again, that barrier method, it can help reduce the risk of STIs because pills does not protect from that. So then you have your progesterone-only pill, which is called the mini pill, and it provides the same action as the oral contraception. The pill has the same time to ensure effectiveness, but this one you cannot miss a pill, and the client cannot need another form of birth control method during the first month of use of this to prevent pregnancy. Again, they have a fewer adverse effects, and this is safe while breastfeeding. The disadvantage is that it's less effective in suppressing ovulation. It increased occurrence of ovarian cysts. There's no protection against STIs. Breakthrough irregular vaginal bleeding. It can cause headaches and nausea and breast tenderness. So the complications with this is that oral contraception decrease when given with meds that affect liver enzymes, so anticonvulsants and some antibiotics. Again, any person that had bariatric surgery, lupus, or severe cirrhosis, or liver tumor, or current or past breast cancer are contraindicated to taking this. So there you have the emergency contraception. It's used to prevent pregnancy after unprotected intercourse. It can be used for also if if they had a failed contraception, or in case of a rape, or just after unprotected sex, or other indications why they'd use that. It does not terminate an established pregnancy. And the first dose should be taken 72 hours after intercourse, followed by the second dose 12 hours after the first pill. So again, they need to check for pregnancy within 21 days. Does not provide a long-term contraception. So again, it's used for emergency purposes. So you want to educate those girls who come in for that, or anybody, that this isn't a form of birth control method. They might want to consider some form of contraception because it increases their risk of becoming pregnant. Again, this does not protect against STIs. They may have some nausea or heavier than normal bleeding, or lower abdomen pain, or fatigue, or headache. And again, it's contraindicated if you're pregnant. Here we have the transdermal patch, which is commonly known as the Ortho Evra patch. It contains progesterone and estriol that is delivered through the skin subcutaneously. It comes with 3 patches and 1 week off. For each week they wear 1 patch. They have to place it on either the abdomen, the outer arm, upper torso, or the buttocks. And then they allow, each week they replace it and kind of rotate it in these different sites. And then the last week they're patch free, and that's when they have their period. The thing that you just have to be mindful that it can cause the skin, since it's placed transdermally, it can cause a skin reaction. But the person needs to weigh less than 198 pounds because it's going through the tissues. If they're heavily obese, they have a lot more tissue layers, so maybe a little harder for the medication to absorb to the skin. So that's why the ideal weight is less than 198 pounds. And then this can potentially have risk for deep vein thrombosis or venous thromboembolism, so they just need to be very careful on this medication. Then we have DepoProvera, which is a hormonal injection. And this one is given intramuscularly injection to the female every 11 to 13 weeks. It's a slow release form of progesterone that prevents ovulation. And the injection is given to the patient every 3 months. When they begin this medication, they must be on their first 5 days of their menstrual period. Or for women who are breastfeeding, sometimes they may be given at the hospital after they give birth, or 6 weeks postpartum. But you need to educate the patient that they need to come back at the scheduled time for re-injection. When they're on this medication, they have to have adequate intake of calcium and vitamin D. It may cause irregular bleeding or spotting, or sometimes amenorrhea, meaning no period. It also increased the risk of thromboembolism. One of the things that it does do is decrease bone density due to decreased estrogen levels. So they need to take vitamin D and that calcium, like I said earlier. With this, the side effects, it can cause weight gain, headaches, nervousness, increase in depression. So you want to educate your moms about that when they receive this. If they decide that they want to get off of this, return to fertility can delay as long as up to 18 months after discontinuing this medication. Again, when they insert this, they want to avoid massaging the injection site following administration to avoid accelerating the administration of the injection. Here you have the NovaRing, which is a soft, flexible ring that contains estrogen and progesterone. You can place it in the vagina for 3 weeks, and you leave it there for 3 weeks, and then remove it by the 4th week for menstruation. This one is 98% to 99% effective. Then you have the hormone implant, which is commonly known as the Implanon, which is a progesterone-only rod implant that is a small little plastic rod that's placed underneath the skin of the arm. And a provider can place this in. They just kind of numb the arm area with some lidocaine, and then it has a mechanism where it just kind of inserts into your arm. This provides 3 years of contraceptive protection. It's commonly used for women who are breastfeeding after 4 weeks postpartum. It's a rapid return of fertility if you decide to have it removed. The patient does need to go into the office so that they can remove it out of their arm. The side effects with this is that it can cause weight gain, irregular bleeding patterns. So they just have a lot of breakthrough bleeding, which that means that just after they had their period, and all of a sudden maybe like 2 weeks later they'll have their period again, or just a little bit of bleeding. This also causes women to have acne, depression, headaches, and decreased bone density. And it also increased the risk of ectopic pregnancy. The other one is the intrauterine device. So this is a small T-shaped device that a provider will insert into the uterine cavity. So there's 2 types. There's the one that's non-hormonal that can last about 10 years, which is like the copper IUD. And then in the picture you see the white one that's usually has some sort of hormone in it. And those usually last about 5 years. So this is 99% effective. It's safe for breastfeeding mothers. Can be inserted immediately after birth or abortion or miscarriage. It does increase risk of menstruation and dysmenorrhea, so meaning that it has like a painful period, because they definitely have sometimes a heavier period and may need iron supplements. Women feel they have fine placentas that protrude from vagina to verify placement, so they always have to check the strings every month to make sure that it's placed in correctly. Now, if they don't feel the string, or if the string is longer or shorter than previous, that may be an indication that it's moved, and so they would need to just check it out to make sure that it's in its place. So they need to call the provider. Teach signs of infection, so fever, pain, vaginal discharge, or signs of ectopic pregnancy, meaning the pregnancy is outside, it's in the fallopian tube, not in the uterus. This should be used for a couple that are monogamous because there's a risk of STIs, and because this is in their uterine cavity, if they got an STI and they didn't know it, it could potentially lead to pelvic inflammatory disease, which can cause scarring on the uterus, and it could just be very problematic. So they have the uterine perforation, and again, ectopic pregnancy that could happen. It's very common that the ectopic pregnancy happen because when you look at the picture, it potentially blocks the uterus wall, so that's where the implantation takes place. So instead, when they meet, the sperm gets through that IUD, and where they meet the union of the egg and the sperm is usually in the outer part of the ampulla, which is part of the fallopian tube. And so once it makes it back downward, it's not able to embed into the uterus. So it just may stay in the fallopian tube, and that's not good, because then because that's gonna grow, and then it's obviously not viable pregnancy, and then it potentially can rupture. So that's not good. So again, when you're talking about more education, signs of potential complications with the uterine device, it's that it can be a period is late, abnormal spotting or bleeding, abdominal pain or pain with intercourse, infection, exposure, abnormal vaginal discharge, not feeling well, fever, chills, or string missing shorter or longer. So again, you want to educate your patient about this. So let's talk about permanent contraception. So some people may opt for sterilization, which is a permanent method that's 100% effective in preventing pregnancy. In some cases, it may be reversed, but it's costly and it's not always successful. So we really need to make sure that this is what they want to do. There's no more worries of becoming pregnant. There's no risk of pregnancy to be zero. It's permanent. The only thing is that some people, that's why you really need to think hard, because you don't want to regret the decision later. Because some people may get divorced, remarried, death of a child, or change in attitude towards having children. So And there can be some surgical complications, but it's very minor. So one is a male sterilization. It's what we refer to as a vasectomy. So this again is permanent. So what they do is they cut in each side of the scrotum and cut the vas deferens tube in which sperm travels. Um, Usually this is an outpatient surgery. It takes about 20-minute procedure. There may be a little bit of pain, swelling, and bruising after the surgery, but the patient needs to report bleeding, any substantial bruising, separation of suture or drainage, or any increasing pain. They need to use, one of the things that's very important is that they still need to use a backup method until all the sperm has left the system. They will still be able to ejaculate, it's just that they don't have the sperm in the semen that cause fertilization. So they have to ejaculate at least 20 times or 1 week to several months to allow all sperm to be clear. So they need to come into the clinic to have a sperm analysis to make sure that there's no more sperm in there. And usually the sexual function is not impaired when they have this procedure done. For women, we have two types. We have a transcervical sterilization, which is insertion of a small flexible agent through the vagina and cervix into the fallopian tube, and it results in the development of scarred tissue in the tubes, preventing contraception. The examination must be done after 3 months to ensure fallopian tubes are blocked, and normal activity can be resumed by most clients within 1 day of the procedure. The advantages is a quick procedure, does not require no general anesthesia, there's no hormonal means as birth control, and is 99.8% effective in preventing pregnancy. And again, there's a rapid return to normal activity of daily living. The disadvantages is not reversible, not intended for postpartum clients, delay in effectiveness for 3 months, alternative birth control method until confirmation of blocked fallopian tubes. They may cause changes in menstrual pattern, does not protect against STIs, or perforation can occur to increase risk of pregnancy. A surgical procedure consisting of severance or being a block the fallopian tubes to prevent fertilization. So this is for female sterilization. So this is the cutting, burning, or blocking of the fallopian tubes to prevent the ovum from being fertilized by the sperm. Again, this is permanent, can be done immediately after childbirth within 24 to 48 hours. Sexual function, again, is not affected. The only thing is that for disadvantages, that it requires to be a surgical procedure carrying risk related to anesthesia, and it's irreversible, and it does not protect against STIs. Lastly, let's talk about infertility. So infertility, the definition for this is that it occurs when a couple who has regular unprotected sexual intercourse for 1 year and cannot conceive. So they just, for a whole entire year, they have unprotected sex and they just are not able to get pregnant. Or it could be a 35-year-old who has no known risk factors. For them, if it have unprotected for 6 months, then that be considered infertility. So partners who experience infertility can experience stress related to inability to conceive, expense effects, coupled relationship may be affected, and a lack of family support. So assumptions of fertility: assume that they are fertile and postpone pregnancy to pursue education or career goals. So a lot of women are now postponing pregnancy to, finish school, or they want to travel and do things. But as we know, the prime childbearing ages are in the 20s for women, and most women are waiting until the 30s. So sometimes that decreases your fertility as you continue to wait longer and longer as you age. So usually what happens is once the decision is made to have a child and start, their expectation is to get pregnant, and sometimes they get very discouraged after each month passes and no pregnancy. So of course that can be really hard on the woman, because she may feel a sense of inadequacy, or may not feel like a woman because her body's just not naturally conceiving like the way she expected right away. So they go through some psychological reactions. They may feel a little shock. They may feel guilty now because I waited, this long to have a child. And now I'm feeling isolated because all my friends are having babies but me. And sometimes those people can't share that joy because of the fact that they're not being able to have their child just yet. And sometimes some of these women may start to become depressed because they start to feel really inadequate and start to stop losing hope that they can potentially get pregnant down the road. And then that could put stress on the relationship as well, because one can blame the other that they're the reason why they can't get pregnant, or they stress so much about trying to have this baby and it's not happening the way they wanted it to. And then there's cultural and religious considerations when it comes to this as well. So when the male, if it's a male is the one that's affected with fertility, it can be abnormalities in the sperm, with erections or ejaculation or seminal fluids. For the female, it could be disorders of ovulation. It could be abnormalities with her fallopian tubes, her uterus, her cervix or ovaries or hormone. Other factors, it can be how often do they have sex. Is it not often that they're having sex while they're fertilizing? So that can also affect it. Their age, how old is the mother and the father? Because as I said before, as we get older, it starts, decreasing your fertility. Cigarette smoking can affect as well. Exercise, diet, and weight. If there's emotional factors or medical problems or drugs and chemicals, that can also play a factor in fertility. So again, for the male, they'll do like a semen analysis, they'll do an endocrine test, ultrasonography, and they'll do a testicular biopsy. For females, they also do an ultrasound, they'll do a postcoital test, endocrine test, hysterosalpingogram, just to also look at the fallopian tubes. They look at the uterus with the ultrasound. They'll do an endometrial biopsy, and then they'll do a hysteroscopy. Sorry. So therapy for infertility. Usually they will consider medications to help increase fertility. There may be some surgical procedures, therapeutic insemination. Some patients, depending on how successful they were, if they were unsuccessful, they might just opt for surrogacy. Or they can do IVF in vitro, and there's different ways of doing in vitro and the transferring. It can be very, very, very expensive, especially if it is not successful the first time. So again, that can put a lot of stressors on the patient and the couple when they go through this process. And again, the outcome is obviously we want to achieve pregnancy to viability so that she can have a baby. And there's times that those procedures are going to be unsuccessful, or that they get pregnant, there's a loss after the treatment. So again, we need to be supportive with these patients that they're going through this, because it may be very hard for them. Then you have their legal and ethical issues with surrogacy, finding the person who's going to carry the child, the legality with that, as well as the financial component, parental rights. There's also issues with people, cloning issues or sale of frozen embryos. There's always going to be some debate about those kind of issues. But again, nursing care related to fertility treatment, we want to support the couple, and that's the most important thing as they're going through this process, because it can be very hard. And teaching coping skills to how to deal with this, and how to deal with loss, and how to deal with, they might be disappointed and might, hoping that it might work or it might not work. So how to cope with those is really helpful in teaching those skills.
10 o'clock.
All right, this concludes this lecture. If you have any questions, please feel to email me.